Hey folks, this is part two of the dopamine blocking drugs series. Sorry, for some reason this didn't make it onto the original Canvas set, so I'm adding this at a later date, which is why my video picture looks different. So in this section, we're going to talk about the mechanisms of action of these drugs. So dopamine blocking drugs are a group of drugs, historically we've called antipsychotics, but as you can see, they have utility in other conditions beyond psychosis. So this is, of course, classically the group of medications that we use to treat schizophrenia and also bipolar disorder, particularly the manic episodes, um, uh, can be treated with first generation antipsychotics and most of the second generation antipsychotics or dopamine blocking drugs. There's a handful of the second generation antipsychotics that also have utility in treating bipolar depression. We'll get to that later. That was talked about in we'll talk about that in a little bit later module. We also use dopamine blocking drugs in the augmentation treatment of major depression, unipolar depression. These are a staple of treatment for acute delirium and agitation in the hospital. So things such as methamphetamine-induced psychosis is another place where we can certainly use these. And these are used in an off-label capacity, usually in very low doses for agitation in dementia, despite there being a black box warning about that particular indication. Um, so fundamentally, all dopamine blocking drugs, first and second generation, or typical and atypical, as they're sometimes referred to, have to block dopamine to some extent, or at least modulate it. But generally, they are dopamine blocking drugs. And the first generation medications, they only blocked the dopamine receptors. Typically, they blocked all of the dopamine receptors, all five dopamine receptors, when really what we want to really target is dopamine 2, the D2 receptor. But regardless, the first generation just is kind of like a wet blanket that just covered all of the dopamine receptors. And what this accomplished was by blocking them in that mesolimbic pathway, which we've talked about before, you can quiet down those sort of what are sometimes referred to as positive symptoms of psychosis, remembering that that's not a judgment that those are good things, but rather these are things that are added to the person's psychic experience. So hearing voices, feeling paranoia, seeing things that aren't there, those are considered positive symptoms of schizophrenia because they're things that are added to the brain's experience. So these are thought to be generated largely from the mesolimbic pathway, and this pathway can be blocked with these drugs, and you can quiet down some of those positive experiences, sorry, it's late when I'm doing this, positive symptoms, not positive experiences. Now, there's a sort of a sweet spot with dopamine blockade, and you typically want to block about 65 to 70% of those D2 receptors. If you overshoot that, you tend to cause nothing more than side effects. So you don't get additional antipsychotic effects. You really just cause extrapyramidal symptoms and hyperprolactinemia. And you need to, in order to get that antipsychotic effect, I think I may have misspoke, you need about 60 to 65% of those D2 receptors to be blocked at least for one time a day. Now, the problem with these first generation antipsychotics or dopamine blocking drugs is they really didn't do much for the negative symptoms. So the avolition, the thought blocking, thought withdrawal, those are considered negative symptoms because they're sort of taking away from the person's brain experience. So by blocking those receptors in the mesocortical pathway, which is where we do a lot of our thinking, these symptoms actually often kind of got if not if unaffected, sometimes even worse. So you see this sort of, what sometimes people colloquially will refer to as feeling kind of like a zombie. Um, And the problem with blocking those dopamine receptors in the nigrostriatal pathway is that you got these tremors and Parkinsonian type symptoms, the drug-induced Parkinsonian symptoms that are often referred to as EPS, extrapyramidal symptoms. So these sort of acute movement disorders that we see with dopamine blocking drugs. And when we blocked it in the tuboinfundibular pathway, that caused prolactin to be released from the pituitary. And so when you see prolactin rise, we see gynecomastia, we can see galactorrhea in all genders, and that certainly can be alarming for somebody who has not just had a child. So elevated prolactin was another side effect because of this blockade of dopamine receptors in the tuboinfundibular pathway. So well, Clozaril was the first atypical or second generation antipsychotic comes out. I mean, I think it was actually FDA approved around 1987, 1988, but really the sort of early 90s and into the early 2000s was the sort of height of this second generation antipsychotic development, these meds kind of rushing onto the market. And what made them different was that they did have that dopamine, so this SDS is serotonin dopamine antagonist. So what these are doing is they are blocking dopamine receptors, specifically more targeted towards the D2 receptor, but they're also blocking the serotonin 2A receptor, which is different than a first generation antipsychotic. So that's the thing that really makes these dopamine blocking drug generations different, is that the first generation wet blanket across most of all the dopamine receptor types. Second generation medications more specific to D2, and also additionally and critically, they have this serotonin 2A antagonist property. Now, they may have other receptor activity as well, which is what this stall uh, diagram indicates. So, they may hit histamine receptors such as quetiapine, which makes it a very sedating medication. They may have some inhibition of serotonin and norepinephrine reuptake, as does a medication like ziprasidone, as I think it's pointed out in the GAMI book. So the atypical antipsychotics or second generation antipsychotics have a whole range of different receptor activities. Now, a single drug is probably not going to hit all of these different receptors as shown in this schematic here, but it just kind of gives you an idea of all the different ways that they might hit different receptors. And so with the second generation medications, with the atypicals, we're still blocking dopamine in that mesolimbic pathway. And that's going to help reduce those positive symptoms of psychosis. But we're going to do something that's really critical here. So we want to block dopamine in the mesolimbic tract, but we want to actually increase dopamine in the mesocortical tract. So that area of the brain, the cortical area, the way it connects to the midbrain section, so that's the mesocortical tract. This is where we do a lot of our thinking. And so what we want to do is we actually want to increase dopamine in that area while not increasing it in the mesolimbic tract, because that would make psychosis worse. So we're blocking it in the mesolimbic, but increasing it in the mesocortical pathway. The idea here being that we're going to cause this dopamine to be released and improve cognition. And we're going to do that with that serotonin 2A antagonism. So by blocking serotonin 2A, we actually cause more dopamine to be released in that area of the brain, with the idea being to relieve negative symptoms. And this promise has been kind of only partially realized because we were told when these medications came out that they were really going to help negative symptoms, and they arguably do, but they're certainly not sort of miracle cures. The other idea here is that by blocking serotonin 2A, we cause dopamine to be released in those Niagara striatal pathways where we actually want dopamine. So remember, the Niagara striatal pathway is part of what is impaired in Parkinson's disease. So we have less dopamine activity there, which is why we get these sort of drug-induced Parkinsonian-looking symptoms. So people on dopamine blocking drugs can sometimes have tremors or bradykinesia, and those are dopamine related symptoms that are caused from blocking dopamine in the nigrostriatal pathway. So the objective here is let's not block dopamine in this pathway as the older medications did. Let's let's try and actually have dopamine be released here so that we don't get these kind of Parkinson-like symptoms. And then finally, by blocking that serotonin 2A and not having the full dopamine antagonism, because most of these are not full antagonists of dopamine, um, by having that activity at the pituitary, we don't get this big dump of prolactin, which is going to then lead to all the symptoms that happen when you have elevated prolactin, which we definitely saw with the high potency first generation dopamine blocking drugs like haloperidol. It's fairly common to get prolactinemia, elevated prolactin with these medications. It is possible to have this happen with the second generation medications, particularly one of the more potent ones, which is risperidone, because risperidone has a kind of a similar mechanism, a similar affinity for that dopamine receptor as does the first generation ones, but it's not as big of a problem with the second generation dopamine blocking drugs or antipsychotics than we saw with the first ones. Okay. So here's where things get kind of interesting, right? So I told you somewhere around 65 to 70% roughly is the sort of dose that you need, the the amount of dopamine receptor blockade in order to get uh, those psychotic symptoms under control. However, interestingly, one of the most effective antipsychotic medications, which is clozaril, is actually not that potent at the D2 receptor. It only occupies about 30 to 40% of them, yet it's a very effective antipsychotic. This remains somewhat of a mystery as to why this is the case. But when we get up to this higher blockade, when we're blocking like 90% of the those receptors, we start to see these movement disorders. And in fact, this is kind of a horrible thing, but in the past, when these were being dosed, there was this idea in psychiatry that the amount of drug that it took to get somebody dystonic was actually the same amount of drug it would take to get somebody's psychotic symptoms reduced. So it was not uncommon for these drugs to be dosed with a fairly wide titration. So, somebody might come into the hospital and the orders would say, continue to push Haldol until the person either falls asleep or starts to develop extrapyramidal symptoms, because that was thought that high dose was the same dose that ablated some of those psychotic symptoms, but it actually turned out that that was incorrect, that that was more drug than was really needed. So we don't want to be making people dystonic. Now, how long should it take for one of these medications to work? A lot of times people will be discharged after, a couple of days in a hospital, being started on antipsychotic, and they'll say, well, the medications are working. They're reducing the psychosis. And, the reality is that is probably not the case. Probably what we're seeing is sedation, which can be valuable if somebody is agitated, but they're probably what we're the antipsychotic response, the decrease in positive and negative symptoms, often takes many weeks to occur, not unlike an SSRI takes some time to occur. But definitely in the early days of this, we can decrease agitation. We certainly see that in our emergency rooms. We can help people start feeling less fearful. We can start to decrease the intensity of those delusional and hallucinatory experience. And we want to be modest about our expectations here. A lot of times we're not going to eliminate every auditory hallucination. It'd be great if we can, but a reasonable goal is sort of 30 to 50% reduction in symptoms. And we'll, with time, continue to see less of that intense kind of paranoia and anxiety. With additional time, we begin to see that confusion and thought disorganization begin to improve. That should hopefully translate into improved social interaction and decrease social sort of functional impairment, and ideally getting people out of the hospital and into a lower level of care. But it's often sort of a misnomer to think that a few days on a dopamine blocking drug for something like schizophrenia is an adequate trial. Really, a few weeks is what's really needed to know for sure. Now, I mentioned earlier about how we sometimes use these medications off-label to treat agitation in people with dementia. And there actually is this black box warning around the use of dopamine blocking drugs, antipsychotics, with people with that condition, that it actually increases their all-cause mortality by about 1.6 times. And yet we do this frequently. If you've ever worked with elderly patients, you certainly probably have seen people with dementia and agitation on these medications. And it's not an absolute contraindication, but because of this black box warning, you really do need to talk to your patients, but more importantly, you need to talk to your patients' families, because typically, if a patient has more advanced dementia, they're not going to be making their own medical decisions. That's going to fall in the hands of the durable power of attorney for medical decisions, often a family member. So you want to be talking about this potential risk here and acknowledging that untreated agitation or wandering, for example, comes with its own set of risks. If grandma walks out of the house and walks in the middle of the street and gets hit by a car, then this black box warning is really sort of a moot point. So this is part of the clinical art of what we do, is trying to figure out where is the greater risk. Is it not treating the disease, or is it the risk of the medications? Now let's take a closer look at these side effects. So extrapyramidal symptoms, known as EPS sometimes, this is caused by that excessive dopamine 2 blockade. And the things that are going to be most likely to do this are your high potency dopamine blocking drugs. So those are your first generation meds like haloperidol, and also your second generation medications like risperidone, cariprazine, and to some extent aripiprazole. And these are things such as Parkinsonian symptoms, so sometimes referred to as DIP, or drug-induced Parkinsonianism. So this is stuff like cogwheeling. So you go to move the person's arm, and there's this kind of jerky feeling to passive movement. You can see a resting tremor. You can see this sort of flat Parkinsonian masked face and blunted emotions. Also within this EPS umbrella is symptoms of acute dystonia. So things like torticollis, where the sternocleidomastoid muscles go into spasm and the neck turns and cannot be turned back, or while this is happening, or an ocular gyrate crisis, where the extraocular um, muscles of the eyes go into spasm and the eyes kind of roll back in the head. If you're going to see this, typically you're going to see it very quickly after you start a medication, within a few days. You can treat this with intramuscular benzotropine or diphenhydramine. You don't see this that often anymore, because we sell this more with the first generation dopamine blocking drugs. I saw this once in Havana, Cuba. I was touring a 5,000 bed psychiatric hospital and saw a young woman brought into the nurse's station who was having both torticollis and an ocular gyrate crisis. And about 10 minutes later, left the nurse's station, probably having had an injection of one of these medications, and it had resolved promptly. Akathisia is probably the most common of these symptoms, and akathisia is this feeling of sort of internal restlessness. And so sometimes it can be observed by somebody kind of fidgeting, usually this kind of jumping of the legs, but it often can have just sort of a subtle internal feeling of restlessness. So the best way that I can probably explain this to somebody is if you've ever had a long flight and you can't wait to get off that plane, and you just want to walk, you just want to move. And unfortunately, a lot of times we overlook this because we're giving these medications to people who have agitation, and then they're feeling kind of fidgety and restless, and we think, oh gosh, they're still agitated, and we give them more of the medication and make it worse. So akathisia is actually historically was treated with benzotropine or cogentin. Now is really it's probably better to treat this with propranolol, and you can use these extended release propranolol from 60 to 120 milligrams dosed all at once at bedtime to treat akathisia. Akathisia is often sometimes dose related. So, for example, aripiprazole is really known for causing akathisia if you start too high. So, if you start aripiprazole or Abilify at, say, 10 or 15 milligrams, you're likely to cause akathisia. If you start at 2.5 or 5 milligrams, much less likely to do that. And then tardive dyskinesia, as you can unpack that word, tardive meaning later, dyskinesia being movements, abnormal movements, is caused by this chronic blockade of these dopamine receptors, and they become actually hypersensitized or supersensitized, particularly in the Niagara striatal, those movement pathways for dopamine. Now, people with schizophrenia may already have an elevated risk for this. And in the old days, when we only had first generation antipsychotics, we would definitely see this in people that had been treated with many years of drugs like haloperidol. That risk went down significantly with the second generation antipsychotics, but it's not zero. And I've certainly seen several cases of tardive dyskinesia over the years with the second generation antipsychotic medications as well. So one has to keep that in mind. Certain groups are more at risk for this. Elderly people, young men are particularly at risk for developing tardive dyskinesia later. And interestingly, some of the antiemetic medications which block dopamine, such as prochlorpromazine, Parazine, excuse me, or promethazine can also cause TD if somebody is taking them for a long period of time. And as you can see, this can be a really sort of disfiguring condition because it will cause these motions that usually begin with the mouth. Sometimes will extend to the neck and the head, like this person in the middle, and this kind of lip smacking, and can have truncal or extremities movements as well. This is something if people are um, on a dopamine blocking drug, you need to monitor for tardive dyskinesia. Typically, the Ames exam is sort of the industry standard. There's a video there that's linked. It's also on the Canvas site that will walk you through how to do an Ames exam, and this should be done on a regular basis, particularly with the groups that I've listed here: younger men, people on high potency antipsychotics early in treatment, because that risk does tend to increase at the beginning and then kind of plateaus over time. It's tricky because you often can't necessarily stop the offending drug in this. So the group that I think we can, at least in schizophrenia, in mood disorders, I think this makes an argument for being very thoughtful about how long we have people on dopamine blocking drugs in conditions like bipolar disorder and unipolar depression, and thinking about using alternatives like lithium, for example, in bipolar disorder. There are some drugs on the market now called VMAT inhibitors that refers to vesicular monoamine transporter inhibitors. So these are things such as deutetrabenazine and valbenazine. They are available. They do have some efficacy in reducing these TD symptoms. They're very expensive, which is a deterrent for a lot of health systems to adopt them, but they are available. A more common problem with particularly the first uh, era of the second generation antipsychotics, so your olanzapine, your quetiapine, risperidone, were these metabolic issues. Clozaril was another big problem with this, which often started with increased appetite, increased weight gain, increasing in triglycerides. Then we start to see insulin resistance, diabetes, and cardiovascular effects that go along with diabetes, um, and hyperlipidemia. And this is actually what accounts for a good portion of the significantly reduced lifespan of people with schizophrenia, which has historically been on the order of about 20 to 25 years less than their peers without schizophrenia. So this is absolutely something we need to keep an eye on when we have people on these medications. We need to be monitoring weights. You should have a scale in your office. You should have a blood pressure cuff in your office so that you can follow the guidelines for this that I believe we've talked about talked about in this talk later. The reasons for this are not fully understood, but they may have to do with increased blockade of histamine, serotonin 2C blockade, insulin resistance. A lot of times people get very hungry on these medications. The classic when olanzapine first came out was that people really wanted carbohydrates and fats, so chips and things like that. Sometimes people get dry mouth, they get thirsty, so they're drinking often caloric liquids such as sodas, which adds additional sort of calories. And so anytime you see a patient who you start on this medication is rapidly gaining weight, like they've put on 5 pounds in a month, that is absolutely something to pay attention to. This is, here's the thing I was referring to. This is the American Diabetic Association, American Psychiatric Association guidelines, now many years old, but still very relevant for monitoring at baseline weight, ideally waist circumference, blood pressure, and then getting those labs. So send people for your A1C, your fasting lipids. These are things that you're very familiar with in primary care. And then we're going to repeat that again at 12 weeks, so 3 months later, and then annually, we're going to check those labs. What about other side effects? So that histamine blockade is what is causing not only the weight gain, as I talked about, but also the drowsiness. So think about histamine. When histamine is blocked, we get drowsy. When we block those norepinephrine alpha 1 receptors, that can result in orthostasis. So when people stand up, they get dizzy. That also creates some of the sedation and dizziness. And blocking those acetylcholine muscarinic 1 receptors is what's going to cause things like dry mouth and constipation, blurry vision, the sort of classic anticholinergic side effects. The ones that are worse at this are things like olanzapine and clozapine. Quetiapine is quite sedating because it's antihistamine, and I believe also the noradrenergic alpha 1 receptor blockade. Neuroleptic malignant syndrome, fortunately, a fairly rare thing, but this can be a very serious response to antipsychotics. Typically will happen very early on in treatment, and it has some similarities to serotonin syndrome. So in the same way that you get that sort of fever and you get autonomic dysregulation, so people are going to have issues with their pulse and their blood pressure. They're going to be delirious and confused. With NMS, you also get this muscle rigidity that can happen. So you can see increases in creatine kinase levels, and that can lead to rhabdomyolysis. So this can be a very serious condition, and this is not something you're going to want to treat in your office. This is something to admit somebody into the hospital for because they're going to need ICU level support usually and a drug called dantrolene or bromocriptine to reverse that dopamine blockade. So this is a real serious situation should you I see that. We'll talk more about childbearing age patients when we get to the second quarter. But the quick news flash here is that it appears that the second generation dopamine blocking drugs or antipsychotics are reasonably considered safe in pregnancy. And so we always again have to think about the risks of discontinuing a medication as well as the risks to the fetus from exposure to that medication. So we'll go ahead and stop there and go on to Unit 3 after this. So thanks for your attention. Bye.